Hi, my name is Chiara Bucciarelli-Ducci. I'm a non-invasive cardiologist from Bristol, UK. And this year at EuroPCR 2014, we have organized a session, All You Want to Know About Cardiac MR for the Interventional Cardiologist, jointly with EACVI, the European Association of Cardiovascular Imaging, Cardiac MRI section. It's my pleasure to introduce my co-chairman of the session, Professor Holger Thiele from Lübeck,
Hello.
Germany. Hello. So today the session was very educational, and the audience had an opportunity to learn what the interventional cardiologist can see from MR and what MR can offer them. Would you like to comment on what are the most important information that the invasive cardiologist can gather from MR, please?
Yeah, so MRI has a multitude of potential parameters which it can image. So it can, for example, image the perfusion, it can image the tissue, which is very important, so it can image necrosis, it can also image scar. This is very important, and it's currently the reference method also for the imaging of the volumes and the ejection fraction. And all these things can put together, and you can get all the information of all these parameters within a very short time. And you can also, in acute coronary syndromes, you can also get information on microvascular obstruction, for example, which is no reflow. You can also get information on reperfusion injury, like hemorrhage, in patients undergoing primary PCI and ST elevation myocardial infarction. So we get plenty of information from different parameters from MRI.
So when you compare MR with other imaging modalities that are already available, like FFR in the cath lab or SPECT or stress echo, does MRI have an added value in your view?
Yeah, so MRI has, there are very recent new data out, for example, comparison to other imaging methodologies. So there are data out that MRI is performing better than SPECT, for example, in particular in women. So where it has been shown previously also that in women, SPECT is not so good with respect to sensitivity in detecting coronary artery disease. And MRI is doing much better in this specific circumstance. Also for men, but in particular for women, it's doing much better if you perform perfusion, stress perfusion MRI. What do you think about the EACVI revascularization guidelines? So there will probably an upcoming guideline, so maybe you can speculate about the role of MRI.
Yeah, well, it's interesting because in the session it was apparent that MR is widely used in clinical practice to actually guide revascularization, and it can provide a lot of important information to manage patients and to target revascularization. But actually MR does not have a prominent role in the guidelines, and I think the reason is not because the technique is not good enough, but the reason is because there is not a lot of evidence out there that makes the guideline writers confident that MR can be included in those guidelines. So I think maybe it's a wake-up call for the imaging community, particularly the MRI one, that it's time to start creating the evidence, and beyond the single-center studies that we have a lot of those, but we need to do randomized clinical trials, multi-center, so to create hard evidence that can impact the guidelines at the moment.
Maybe you can speculate, because there are some ongoing trials, maybe you can just speculate on the design of these trials and how they will probably or maybe impact the clinical decision-making in the future.
Sure, because particularly so the reason why the fact that MR is not in the guidelines then has triggered an interest in the imaging community, particularly the MRI imaging community, to actually start building up the evidence. So there are a number of multi-center randomized clinical trials in the horizon, and actually in the pipeline, I would say, because some of those are almost concluding their recruitment, and particularly I refer to MRI in foam and the CE-MARC 2 and the ischemia trial. So they're all trials in stable ischemic heart disease patients, and what is the role of imaging, and particularly ischemia imaging, and in some of those MR in guiding patients' management. So we all look forward to those results, and I'm sure those results will provide the hard evidence that's much needed to see MR in the guidelines.
What do you think about, or can you speculate? Often we have in interventional cardiology, we have patients presenting with acute coronary syndrome, but they have normal coronary artery disease, and so we don't know what to do. How can MRI help us in this situation?
Yeah, sure. Well, I totally agree. That's a diagnostic dilemma, isn't it? To present acutely with ST elevation and not culprit in the coronary angiogram. And unless you do an MRI, actually you have not final diagnosis. And doing an MRI will tell you whether it's acute myocarditis, or it could be Takotsubo, or can it even be a reperfused myocardial infarction? And so all of a sudden you see that it's very important to actually bottom down the diagnosis, because it has an impact on patient management and secondary prevention, prognosis. So it's very important. And I would say among the many patients, this is the cohort that currently is most interesting, and from which MR can, from which they can really benefit from MR. And well, how about contraindications? Because there were a few colleagues in the audience that were really enthusiastic about this new content, but they were wondering what is the contraindications to do a cardiac MR that they should be aware of?
I think the most important thing is what we also have learned from the questions from the audience. So putting in a stent or a previously implanted stent, or maybe also a valve, the aortic position, or maybe also a mitral clip is not a contraindication to perform MRI. This is very important to say. There are only very few contraindications currently where it is an absolute contraindication to perform MRI, which is metallic cerebral implants. Maybe sometimes claustrophobia, severe claustrophobia. However, this can usually be dealt by a kind of sedation during imaging, and maybe also pacemakers and ICDs, which are not specifically made for MRI. So, but nevertheless, this is currently also in discussion if implanted pacemakers and ICDs are really a contraindication. So there are really very few contraindications which you really can deal with in clinical practice without big problems.
So in conclusion, the session was very well attended. It was very informative, very educational. And the interventional cardiologists left the room knowing what MR can offer them and how they should use MR. And most importantly, what is the up-and-coming evidence that will most certainly impact the guidelines, and we'll finally see MR mentioned in those. And I would like to thank both EACVI and EuroPCR. The session was jointly organized between those two associations. Thank you.